Good evening. Thank you for joining us for another Cleveland Public Library The Next 400 digital discussion. My name is Chris Tanaka. I'll be your moderator once again tonight, coming at you from 19 News. It is Breast Cancer Awareness Month, and this is the topic we're discussing tonight. But we wanted to be granular, we wanted to be specific, and we wanted to be focused about Black women's health and minority women's health in relation to breast cancer. Some of what you're going to hear tonight between the facts and the figures and the status of health might be new to you. It might be a little shocking, but it is necessary, it is important, and it is deserved to be talked about and certainly to be moved in a direction of better health and better equity for all women. I have two incredible guests who do work across the country. One right here in Cleveland, Pamela Komen. She's a certified nurse practitioner with Cleveland Clinic, and the other, Kamesha, coming to us from Los Angeles, California tonight, the Community Program Manager for Stand for Her. That stands for Health Equity Revolution. Thank you both for joining us this evening.
Thank you.
It's great to be here. Thank you. I'm honored to be here, Chris.
Well, let's just dive right in. And Pamela, I'll start with you. When we talk about women's health in regards to breast cancer, specifically Black women, how would you phrase the current, I guess you could call it condition or the state of women's breast cancer health here in Cleveland, across the country, along racial lines?
Well, thank you for that question, Chris. For African American women, it's a well-known fact that Black women die more frequently of breast cancer than other races of women. Also, we know that African American women tend to get a more aggressive form of breast cancer when they get breast cancer, and they get it at a younger age. And so across the country and amongst Black women, we are seeing these very high mortality rates that have actually not improved over time.
And Kamesha, on top of these figures, the condition, when saddled with this, how does it affect a woman's outlook on health?
Well, personally speaking, I'm a metastatic breast cancer patient. So when women go to seek treatment, they're seeing a different kind of treatment than they would normally get if they were not African American. So it's a very delicate situation. Mm-hmm. And they know that for the women who are in treatment, they do see a disparity between how they're being treated from their other counterparts.
What is that? Elaborate, please.
Oh, sorry about that.
No, please.
Well, for one, certain social determinants of health have to do with the lack they come from lack of income or transportation issues. Where they live should not determine whether they live. And a lot of times you see very high institutions in our Caucasian counterpoints where the medical facilities where the community where Black women live in are not as high standard as the ones that you would see in these other communities. So, there's a stark contrast between the treatment levels and also a lot to do with cultural competency. Sometimes the medical professionals have a hard time relating to the African American woman coming from a point of misunderstanding, miscommunication. If you're dealing with a woman who has a certain level of education, and you're speaking these high, terms that they can't really understand, the treatment level is going to be a lot different than you get from your other cultural counterparts.
Interesting. Pamela, do you concur with that? And Cleveland obviously has great care with the clinic, but we have a largely segregated community. We have very poor communities that have been well documented since the Great Migration.
Yeah, they have been well documented, Chris. And what Kamesha said is striking. Where you live should not determine if you live. And what we know is that here in the Cleveland area, and I imagine it's mirrored around the country, that certain zip codes, if you live in a certain zip code, it just interprets and health disparity and different outcomes. And so specifically in my role at the Cleveland Clinic, I work for the Cancer Community Outreach Department, and we are laser focused on finding those women and all patients with cancer. We're talking about breast cancer today.
Right.
But we're laser focused on finding those women who have those issues that Kamesha talked about. So I concur with Kamesha in that there are geographical barriers, socioeconomic barriers, cultural barriers. All those things are true.
Yeah.
Now the why of it, we talk about lack of insurance and lack of access. We talk about fear and trust factors. We talk about the fact that African American women, or let me put it like this, many of the research studies out there that have helped us understand breast cancer are done on non-African American women, are done on white women, and we're not able to be confident that the results of research studies translate across races. And so there are many factors that are involved with this. And so, yes, Chris, I do concur with Kamesha.
It's incredible because what you've talked about in this short period of time that we've had this discussion really mirrors some very broad and well publicized
yes,
healthcare conversations over the past year and a half since the outbreak, when minorities, specifically Blacks, were underrepresented in clinical trials for the COVID vaccine, displayed great hesitancy in certain communities and trust because of intergenerational trauma by the medical community, and
absolutely.
a lower rate of access, a lower rate of care, and certainly a low rate of inoculation. It's stunning to me that this is so sweeping and so broad that it would affect African American women as it relates to breast cancer. But that's
exactly.
What it is.
Yeah.
Exactly.
Yeah.
Exactly.
So, with this being the case, and Pamela, I'll start with you because we're here in Cleveland. You said your advocacy is to go out into the community and be laser focused. What are some of the tactics and what is the overall strategy you use to break down some of these walls that are preventing women from getting the care they deserve?
Well, I must tell you that the Cleveland Clinic Department of Community Outreach for Cancer Care from the Taussig Cancer Institute has a pretty sophisticated approach. We have program managers that focus on specific cancers. Breast cancer is just one, like I alluded to earlier. So I'll just stick with that. But we're looking at actually a total of 5 cancers. These program managers are aggressively out in the community, forming partnerships with important community stakeholders such as faith-based organizations and other organizations within the inner city and within these defined zip codes. And they partner with what we call our patient navigation team, which is so key. So we have about 5 program managers and 5 patient navigators, as well as myself, who is the clinician as a nurse practitioner providing clinical oversight. And we combine all of our efforts together to really do a boots on the ground type of approach to the community. We set up programs. We go to different, like I said, faith-based organizations, other community organizations, and offer these services free of charge. And we get people in and we get them screened. We've also partnered with our federally qualified health centers within the inner city to bring in patients. We will go just about anywhere. We have no boundaries in terms of reaching disparities. We'll go just about anywhere and bring anybody in who is underserved and underinsured. And we, message that everywhere we go.
So that is a very tangible effort that you just described. Kamesha, first off, I'd like to ask, beyond the hesitancy, are there any social stigmas within the community about maybe even reaching out for help or getting screened? Are there any social stigmas that stand in the way of a woman seeking either preventative care or treatment? And secondly, as much as Pamela described the boots on the ground effort, what broad strokes, what kind of macrocosmic efforts need to take place so Black women are elevated and are more aware of the care that they can seek?
Okay, well, I'll touch on the stigma first.
Yeah.
I think it's just an distrust in the community. Ms. Pamela had mentioned it before. There is a distrust with the medical community. Not to say that the medical community has not increased their availability to the Black community, but just from hundreds of years ago, from our experience as African American women and people, we've had some issues with getting credible care or equal access to care. And I think it has built a fear within the community where, and another thing is you get women deciding whether they're going to take care of their kids or go to a doctor's appointment. You're getting women deciding whether, am I going to spend gas on going to this doctor appointment that's way out of my zip code because the better care is in another area, or am I going to stay where I am and get the care that's affordable to me? And then on other stark contrast, I'm sorry, Chris.
No, go ahead.
Okay.
Yeah.
On the other side, what's being done, and I relate with Pamela so well on the patient navigation aspect. Susan G. Komen, we have a treatment assistance program. It's a national treatment assistance program, and we invite women to call our helpline, our breast helpline, and it gives financial assistance. And also the breast helpline also helps with finding resources for women who are going through breast cancer. Stand for Her, as a community program manager for Stand for Her Health Equity Revolution, we are also engaging the community through patient navigation, which is definitely a key term. On a national level, we have 10 cities that have shown the highest rates of breast cancer mortality in the United States. So we've implemented this patient navigation program where we're training people on the ground who are doing the clinical work, the social workers, the nurses, all these people that are putting their foot in the ground, where we have a patient navigation training program that we're implementing into these cities. So everything that Pamela has been doing, I worked not only at the headquarters level, but I worked at the affiliate level, and it was all grassroots. You really have to get into the neighborhoods. You have to talk to the people. You have to work with the faith-based organizations. You have to work with the FQHCs, the federally qualified health clinics that are in these communities where the care is not as affordable as being in a nicer part or a larger medical facility of somewhere else. So it's really getting face to face, really talking to people, getting down there, helping them to understand, this is life or death. It really is. I was diagnosed at 29, and then I was re-diagnosed last year due to COVID. So, and I share my own experience, but I'm also an advocate. I'm a self-advocate. And I believe in self-advocacy, and we try to encourage women to be proactive about their breast health. And that's how we get them in the door. That's how we get them screened. That's how we get their diagnostics done. But there are other barriers that they've encountering, access to care, in those things. You know,
That's
so.
incredible. Let me ask you this, and this is personal. I understand. When you advocate and you so openly share about your own health situation and being a survivor, is there ever any shame or embarrassment that you run into with other women who are, you know, afraid to talk about it or don't want to talk about it because it's so highly personal?
Yes, it's not only highly personal. Traditionally, you did not speak about cancer in Black families. This was something that you did not bring to the dinner table. As a for familiar for me as a Black woman, Black women are, you know, are the backbone of the household. They are the backbone of the household, and you have to maintain your strength. You don't want to show any weakness. So talking about cancer, talking about your family history of cancer was not something that was implemented even down to my generation, was not implemented in the family to really talk about your family history and what was going on.
Wow.
Mm.
So talking about it's a start, I guess, in a way.
That's a start. That is a start.
Yeah.
Yeah.
You mentioned last year, and one of my notes, I was wondering, and both of you please dive in on this. What have you noticed in the past year and a half since the country has gone into the pandemic in regards to people coming in for screenings and on down the line?
Yeah, it's a good question. I have to just touch on the fact that when the pandemic hit, you know, I was at first surprised at the polarization, almost immediate polarization, that African Americans and people of color were getting hit harder and dying more frequently of COVID-19. And it just really, you know, kind of laid bare the underbelly of the system. It really magnified the health disparities in the United States. Um, and, and certainly people were afraid to come into, we became distracted and just focused on staying safe and not catching the virus. And so I am certain that we will begin to start to read statistics of how many people miss their screenings and those implications down the line in terms of missed cancer screening and then later staged diagnosed cancer. I'm sure that data is evolving right now. Interestingly enough, the Toxic Cancer Institute Department of Community Outreach kept screening during COVID. They figured out a no-touch way to get patients into the mammography suite from the curbside. It was an incredible, I can't take any credit for that though. That was the work of our program managers and our navigation team, where they were bringing people from curbside into the mammography suite in a no-touch manner and still getting mammographies done. So, but I don't know that everyone had that kind of creativity, and I'm sure there's missed screenings, Chris.
Right. Well, I mean, look, Cleveland Clinic is one of the best in the world. Have you noticed, has there been a resurgence of the number of screenings or women coming in the past couple of months, few months, 6 months, whatever it may be?
Well, you know, we've learned a great deal since the pandemic first hit. You know, we've gained a lot of information about how to stay safe. And with that being said, we are doing a lot of mammograms. I don't have the specific numbers in front of me, but we have metrics that we follow in our department that we intend to meet, and we set early in the year, and we're, coming down to this last quarter, and in a recent discussion of metrics, we're meeting our metrics, meaning that we are getting people in and we are getting them screened. I'm very proud of the team that I work with.
Absolutely. That's so uplifting to hear. And Kamesha, what have you noticed about the pandemic as well in your work as a program manager? Has there been any sort of, peaks and valleys, or I should say valleys and rises as we have gotten more people inoculated?
The more we did a landscape analysis on the different regions that we've covered nationally with the 10 cities that we've worked in. And there has been a decrease in the screenings over the last year, well, almost 2 years now. And there has been an increase in later stage diagnosis among African American population due to the COVID and not getting their screenings done. So that's not that there are statistical data that relates to that. I actually read that as in general cancer patients, for every one white Caucasian who was diagnosed, 3 African Americans were diagnosed. So there is a need. There is a huge need right now to get people back into their screenings, to get them back into. And I know it's a delicate situation the way that Pamela explains. I don't work in a medical facility, but going to my own doctor's office, you walk in, you put your mask on, they have you at the door, they take your temperature, you can't sit next to anyone, the doctor's all masked up, gloved up, they're still taking precautions, but I think people still have that fear. So they still have a fear of getting their screenings done. From what they were originally told was generally not to go to the medical facilities until everything was cleared. So it was a miscommunication at some points.
Interesting. That's very interesting. You said Kamesha, you were first diagnosed at 29.
Mm-hmm.
Is that correct?
Yes.
That seems, am I naive to say that seems young?
It seems young, but African American women have the highest rate of later stage early diagnosis than any other counterpart.
So if you were 29, and again, this is another personal question, but I think you're such a powerful speaker because you speak so genuinely. Let me ask you what your experience, what your discovery experience was like, because maybe this resonates with women who might be watching this.
So basically how it came about, how I...
Absolutely, yeah.
Basically, I was very overweight. I was about 50 pounds overweight. So I lost a lot of weight. I lost about 50 pounds. And I was running one day and I started feeling a pain in my right chest. I went to my mom. My mom at the time, she had worked in nursing for almost 30 years or so. And one of my my areola was inverted, which is one of the which is identifiable markings as something as breast cancer.
Right.
So I went to the doctor and immediately they took me in for a biopsy. They did the mammogram, immediately did the biopsy the same day. My mom was in the back room crying because she knew automatically if it was that urgent. So at 29, I was diagnosed stage 3 with invasive breast cancer, invasive carcinoma, which was ER positive. So it was estrogen positive, which is the most common type of breast cancer. I mean, as far as the hormones are concerned. And then I just went through my radiation, my chemotherapy, and I was in remission for 6 years until last year. And then it came back. So, but that's not something that's uncommon in the Black community of breast cancer patients. It's not uncommon.
So it was just one single instance of pain. There wasn't like you're ignoring this or trying to put it into the back of your mind, like I'm feeling something. It was one singular instance of pain.
Yeah, yeah, and I had an aunt who had, I had an aunt and um a great grandmother that had breast cancer, but it wasn't something that we took in our family as something so critical or something that should have been talked about. And now I have a 32-year-old niece who is also battling stage 4 breast cancer.
It's terrible.
Yeah.
So
Yeah.
let's just be very open here, because a lot of medical information that, and as you both say, cancer maybe not talked about around the dinner table. Pamela, take the lead on this. What do young Black women need to do regarding their breast health, in regards to self-education, self-examination, getting screened? Give us a timeline on when they should do things throughout their life and what they should be doing.
Well, I'll tell you, Chris, as I sit here and just, my knee gut reaction to that question is remembering back as a young girl, probably, maybe 18, 19, even 20 years old, and having my first OBGYN appointment. I remember the rigor with which, at the time, the physician told me to check my breast every month. And I don't have the exact statistic, but I think the majority of breast cancer is discovered by the woman. And so self-breast exam is just critically important. That's what young African American women can do. We can make sure that we're educated about breast cancer. And the message that Black women tend to get it younger and get a more aggressive type of tumor is messaging that our physician counterparts and colleagues and nurse practitioners and nurses and healthcare providers need to get out there, because I want African American women to just understand and realize that we don't oftentimes fit into the research that's out there already, and you have to be more aware that 40 is the age of first mammography. That is the recommendation and standard that's out there, and we don't have the research specifically in African American women as to when we should get screened. But I think knowing your family history and doing self-breast exams are critically important, and seeing your doctor on a regular basis. The thing about breast cancer, Kamesha talked about the pain that she had, but many times it's absolutely asymptomatic. And so, but for feeling around in the breast and feeling for a lump, you would miss it.
Wow. I want to take a pause here and just acknowledge my own male naivete to some of these topics that a large portion of the audience may already be aware of, but I want to use it as a tool to ask you questions that can really open up this conversation in a genuine way, so we can speak plainly about these courses of action that are so critical for health. And, self-examination, just that term can spark fear, whether it's emotional, whether it's intellectual self-examination, or physical. But I think what we all need to realize is it's the best course, even though it might be frightening, even though it might be intimidating, to address a problem before that problem can get bigger.
That's
in
right.
this case, quite physically. Kamesha, what do you add as far as self-examination for young African American women, what they can do, what they should be doing, on top of everything that Pamela just said?
Well, definitely starting with their OBGYN starting at 20 years old. They should be getting their clinical breast exams when they're going to the doctor. Komen is very big on making sure that they are seeing their doctor. They're being educated about their clinical breast exams at 20 when they originally start. going for their pap smears, and then eventually making sure that if you know your family history, discussing with your doctor about when you should get those screenings done. I know there are states, there are national standards on when women should get their screenings done, but it should really come down between you and your doctor. When is the best time for me to get that screening
That's
done?
right.
Yeah.
Because if I would have known, I would have gotten it at such a young age, and maybe let's say I had a mother or a grandmother who had it in her early 30s, they would have started me off about 10 years previous to when they had gotten their first diagnosis, and they would have started screening me earlier if I would have known that history in my family, if that history had been there. So it's really between the clinician and the patient to really find out when is the best time for me to start really being concerned about my breast health care.
Yeah. I want to ask each of you two more questions that you can both answer in turn. The first being, and Pamela, I'll start because you're physically here in Cleveland. For our audience who's watching live on Facebook and in perpetuity as it exists on the Cleveland Public Library's Facebook page, what are local resources that women can take advantage of right now?
Well, local resources are at the Cleveland Clinic. We have walk-in mammogram clinics. I think that is one of the best barriers, or the best approaches to a barrier that I've seen. I've even taken advantage of it myself. And so you can walk in. We have locations, about 6 or 7 locations, where you can go without an appointment, walk right in, get a mammogram. Also, we have our team, and I'm going to give you our phone number for our cancer answer line, that if you're a woman and you're out there and you need a breast examination, our patient navigation team will do whatever it takes to get any woman in who does not have that insurance. If you don't have a ride, I could tell you an anecdotal story about one of our navigators actually watching a woman's child while that woman went into the mammography suite to get the mammogram. We will be right by your side. And so there are resources. Just to speak to some of the barriers a little bit quickly, briefly, one of our federally qualified health centers, I think there's only one of them that has a mammography machine. And so the Cleveland Clinic has partnered with some of those federally qualified health centers around the community. We will bring women in. We have mobile clinics that we will go to locations in communities, and you can walk right into the mobile unit and not even come into a healthcare facility. You can walk right into the mobile unit, right off the street, effectively, and get a mammogram. So those are the resources. And at whatever point you're ready, Chris, I want to give you our 1-800-CANCER ANSWER phone number.
Absolutely. And maybe our administrator, Michael Young with the library, can put that number up on the screen afterwards. So go ahead, Pamela, please.
And for anyone who's listening, that is 1-800-865-1125. Again, that's 1-800-865-1125. And, whoever answers will be able to direct you to who you need to be directed to in order to get these screenings done.
Wow. Just pick up the phone and call and ask questions. You don't have to know
anything. Just ask for community outreach. Right. Or just say, listen, I need a mammogram and I don't have insurance and I don't have a ride. I don't have a way to get there. And we will take care of you.
Oh, that's incredible. Incredible. Kamesha, obviously you are coming to us from Los Angeles tonight, but you work with Komen, which has a strong footprint here in Northeast Ohio. What are
Yes.
other resources or another resource that you would recommend to women in Northeast Ohio to really empower themselves for their own breast health?
Well, as I mentioned before, for women who are having any breast health issues, breast health questions, they can go to 1-866 go Komen, which is our breast health helpline. And then also they can also visit, they can get in contact for our treatment assistance program for women who are actually going through breast cancer at this time. There's a certain stipend that they get, financial assistance, in order to help them with any type of, medical bills, medication, things of that sort. They also are welcome to contact. I personally, as a great resource, Patient Advocate is a national website, and a lot of different great resources they have that on there too.
Okay, fantastic. And of course, if anyone watching this live didn't necessarily get all the information, don't worry. Once we stop this video, you can just slide across and play it as many times as you need to get those numbers. And when we're done, I'm going to make sure I get these numbers written down and shared because they're very important and valuable for women to have. This is such an incredible conversation. I want to end with each of you tonight. If you can speak to, not to me, but to a young woman out there who either may be afraid to reach out, unable to reach out, be wondering, what goes into a mammogram, and I've heard it's painful and scary and clinical. Kamesha, I'll start with you because you are the survivor. What do you say to a young woman watching tonight?
It is better to know early. Early detection saves lives. That is very true. If unfortunately, I didn't have the option of knowing that it was an early stage, but the earlier they can stage it, the higher rate of survivability that you have. If they can catch you at a stage 1 or 2, there's a 96 to 97% survival rate. And that rate goes down as the stages get higher. So my biggest thing is to just know your body, speak with your doctor. If you have any questions, don't be embarrassed to ask your doctor. That's what they're there for. If you don't feel that you're understood, you always have the option. You always have a second option. So, don't feel embarrassed. Don't feel intimidated. That is what the doctor is there for, to help you with your body. And you know your body better than anyone else does.
Yeah,
Mhm.
great stuff. Pamela?
And what I would say to any young woman that's listening is that in my personal walk, I have seen more than one woman, young, under the screening age, get breast cancer. And I have personal experience with women who have been devastated by this. And I have to just piggyback on what Kamesha said. The earlier you find it, the higher your chances are of survival. And so I would say to any young woman out there that health is wealth, that's real wealth. If you're facing any barrier, please know that there are resources out there for you. And this is something that you're going to be doing for a lifetime. So make it an early habit now. I've gotten, I'm going to tell my age, but I've gotten almost, 18 years of mammograms behind me, going annually. And it really is brief. You're in the mammography suite for a brief period of time. It's not invasive at all. And I personally don't find them to be uncomfortable. Some women do, but it is nothing compared to the comfort that you have in knowing that your breasts are clear of cancer. And so it's a very worth it endeavor. And you owe it to yourself. You're worth it and you owe it to yourself to stay healthy.
Absolutely. I'm so touched by both of your candor, your honesty, your expertise. and of course your lived experiences in this conversation. Cancer touches everyone. I've had 2 instances of breast cancer in my own family, and I'm just fortunate enough to be part of this conversation and learn so much from both of you tonight. I hope that our audience learns something. I hope they understand the stakes, and I hope they value their health and can in some way reach a point of elevating that through some of the words that you both espoused so incredibly. So to Kamesha Miles, thank you so much. She's a community program manager again for Stand For Her. That's Health Equity Revolution. Of course, she also works with Komen. Thank you for joining us from Los Angeles. And Pamela, of course, with the Cleveland Clinic here in Cleveland, always ready to serve her community, which we know must strive for greater equity, especially when it comes to women's health. Thank you both so much for joining us, and thank you for watching another Cleveland Public Library, the Next 400 digital discussion. I'm Chris Tanaka. Have a great evening.
Thank you so much for having me. Bye-bye.
Bye-bye.